All right, well, welcome everyone. It's a delight to be here. Our task was to continue on some of the great research that was done at ASCO, and if there's noise in the background, it's because I'm in the clinic workroom. But I have a few studies that I wanted to share with everyone if they had not seen these before. We're going to start with the NRG-BR002 study. This is an important trial tackling the concern about oligometastatic disease and breast cancer. And this was expertly presented by Dr. Stephen Shimura. And we have really taken his slides here. So this is nothing that I have credit for, but an important trial. So this was a phase 2/3 trial of standard of care therapy with or without the addition of stereotactic body irradiotherapy for patients with oligometastatic breast cancer that was conducted through the NCTN and led by NRG. So oligometastatic breast cancer is something that we're seeing, that we've seen for a long time, and that as our therapies improve, is very tempting to consider trying to move the line in terms of what patients that we're able to offer long-term curative therapy for. And so again, as everyone here is well aware, oligometastatic disease has different definitions, and there's a recent paper that goes through and kind of breaks this into several different buckets or categories. But we all know of patients that we care for in our practice who end up having maybe a single site or a limited site volume of disease outside of what can be generally considered to be encompassed with curative therapy. And the notion here, based on some previous work, is that perhaps if we go after and try to treat with curative intent these other sites of metastatic disease, that metastasis-directed therapies may lead to improvements in both progression-free and overall survival. And this idea of metastasis begetting additional metastasis, that if we can somehow eradicate those, that we may improve disease-free or progression-free survival. This is a trial that led to the background of the NRG study. This is the Sabre Comet trial, which has been much discussed, much panned and reviewed. That this was a phase 2 trial that looked at the use of stereotactic radiosurgery for a variety of solid tumor histologies. And the most common indications included in this trial were lung, breast, colorectal, and prostate. And what this showed is that there was actually an advantage in overall survival associated with the addition of stereotactic radiosurgery. And this has led to the NRG trial, and there are a number of additional trials that are based on Sabre Comet that are looking at different numbers of oligometastatic disease, and there are additional phase 3 studies ongoing. But this was very provocative, suggesting that perhaps treatment of these limited metastatic sites may lead to better outcomes. And so this is the schema for the design of the NRG-BR002 trial. Patients with oligometastatic breast cancer who had controlled local regional disease and less than or equal to 4 metastasis by standard imaging. And so this was primarily with CT and bone scan. PET-CT, FES were not incorporated into this trial. But patients were then randomized 1-to-1 to arm 1, which included standard of care symptom-directed palliative therapy, versus arm 2, where the radiation was used in addition to standard systemic therapy with a goal of total ablation of all sites of metastatic disease. And this included 125 patients. The stratification factors are shown here. I guess important points to notice that, again, about 80% of the patients enrolled had hormone receptor positive HER2 negative disease. 72% received endocrine, and a lower proportion received chemotherapy. And about 60% had 1 metastasis, whereas 40% had 2 to 4 metastasis. And so again, as we would often expect, potentially patients with more indolent disease that's hormone receptor positive with maybe a bone met or 2. And so again, I'm taking from Dr. Chimura's slides, but what this study was highly successful in showing that they were able to successfully deliver SBRT or Sabre type radiation therapy in a multi-site trial in a very safe and consistent fashion across the different sites. So they did a really great job from the radiation oncology perspective, I believe, in terms of controlling and making sure that the dose that was treated was appropriate and was safe. And so that was one of the takeaway points. This slide shows the progression-free survival, which unfortunately was completely unchanged with the addition of SBRT to standard of care therapy. And so the way that this trial was designed is that it was initially a phase, they enrolled the initial 100 and some patients, and they were looking to see a signal in progression-free survival that would have led to additional enrollment in the phase 3 portion. And what this shows is, number one, patients with generally hormone receptor positive, HER2 negative breast cancer have their survival is improving as both assessed by PFS and OS, but the PFS in the arm for the patients who received SBRT was not improved with the addition of radiotherapy. But again, I'll editorialize and say shortly that this is actually pretty standard for what we would expect for patients receiving first-line therapy for hormone receptor positive, HER2 negative metastatic disease. And this, again, likely reflects the improvements that we've made in this patient population. And so sadly, this trial did not meet the primary endpoint. When we look a little bit closer, there was, again, these are subset analyses that are meant to be just only for hypothesis generating and to make us probe a little bit more. But there were some differences with regard to the number of metastatic sites. And again, even some suggestion that patients with triple negative disease may have more benefits. So again, not much, again, to say here other than some provocative data. So in summary, sadly, this trial that we were hopeful would show benefit, failed to show any significant improvement in progression-free survival for patients with oligometastatic breast cancer, and this was a no-go signal. So the phase 3 study will not be completed. I do think it's super important as these patients will be followed, because actually overall survival is really the most important endpoint, particularly for patients in this circumstance who may have a long journey ahead of them with regard to their disease course. Additionally, they were able to prove that the high dose stereotactic body irradiation was safety with low rates of treatment adverse outcomes, which was actually much improved compared to the SABRE-COMET trial. And this was, again, a testament to the study team and their design for quality assurance and safe delivery of the radiation. There are a number of additional trials that are continuing to go after this question. And some of these are listed here and were discussed by Gaurav Gupta in his excellent discussion of this abstract. But I don't think that the jury is completely out, although again, it's going to be much more difficult, and patient selection is going to be really key in terms of thinking about how we define oligometastatic disease. Is it disease that occurs de novo? Is it disease that develops over time? And how we think about the right patient selection that may allow us to better identify patients for whom treatment of the metastatic sites is important. So I'd like to go on and with full disclosure, Dr. Davidson gave an excellent overview of the adjuvant session that was the last day of ASCO, and she was not unable to be here today, and so she kindly provided her slides. So this is literally Jen trying to do my best to channel Nancy Davidson, but to provide the slides and the excellent overview that she gave of the adjuvant session on on June 7th. And so her title was In It for the Long Haul, and she made a lovely joke at the beginning, because this was literally the last oral session of ASCO on the last day of the meeting. And so she commented that everyone there was also in it for the long haul. Many of these abstracts are really focused on long-term follow-up. And if you have any questions about this session, the median follow-up for almost every trial described was 8 years. But this is really trying to understand the long natural history of our patients with breast cancer. And this is a reminder that whether we look from the Oxford overview published a few years back, or whether we look at a combined analysis of the IBCSG trials, numbers 1 through 4, we all realize that our patients with breast cancer continue to experience disease recurrence many years after completion of adjuvant endocrine therapy. And that risk of late recurrence is proportional to their original burden of disease as assessed by nodal status. And that's carefully described in these two figures here. And so there are a number of ways that we could think about in terms of trying to improve outcomes and to reduce the risk of later recurrence. And these abstracts that were discussed in this session touched on a number of these potential issues, including patient selection, the sequencing or selection of endocrine agents, combination of agents. Duration wasn't as discussed in these abstracts, but we'll talk first about the IBCSG long-term analysis of high-risk patients, the ASTRA study that looked at premenopausal women with regard to selection of adjuvant endocrine therapy, and a very cool study, the ASTRA 70 trial that looked at the optimal treatment for patients with breast cancer over the age of 70. And so each of these we'll touch on here. So the first abstract that Dr. Davidson touched on, it was the IBCSG-12. And one of the questions that was posed here was, when we think about the addition of adjuvant CDK4/6 inhibitors, it's really important to understand what is the projection of how well do our therapies work at different points over the natural history of disease. And so historically, we've looked at trials testing 5 years of AI versus tamoxifen among high-risk group. And we're trying to really get a better sense of what happened during the first 2 to 3 years, what's the hazard ratio, what does the benefit look like, and how do we predict the survival, or can we learn from prior survival curves about what's the pace and then of when recurrences will develop, and what should we expect over time. And so Meredith Reagan presented a very nice study where they looked at Big 198 at soft and at text to really identify what is the natural history and the benefit of therapy for patients with the highest risk breast cancer. And they used the same definition of high risk as what was used in the Monarch-E adjuvant abemaciclib trial. And so here they pulled the patients from each of these trials who had node positive disease, 4 or more positive nodes, or high-risk features with 1 to 3 positive nodes. And they looked at effects of treatment on invasive disease-free survival at out to 8-year follow-up. And so you can see that this was a relatively small proportion of the patients from each of these trials. The Big 198 looked at patients receiving AI versus tamoxifen for 5 years. Soft and text we're all familiar with. And in text, again, patients in this trial were all premenopausal who all received adjuvant chemotherapy and were randomized to receive ovarian function suppression with tamoxifen or an AI. And again, it's looking at kind of the shape of these curves and when do we start to see the curve split and when is the benefit. And what you can see here is absolute benefit associated with each of these interventions over time, with curves generally starting to show benefit at 2 years, often stable at 3 years, and persisting over 5 years. And so what she was able to show is that for these highest risk patient population, when we generally anticipate and have seen in the past benefits that emerge generally by 2 years and are indicative of those that are often seen at 5 years, and that the relative and absolute treatment benefits that are observed with the addition of AI over tamoxifen are actually pretty similar in magnitude to those that were seen in the Monarch-E trial. But this meaningful benefit, at least in the context of AI versus tamoxifen, persisted. And so this is really particularly helpful, and having that long-term follow-up is very helpful when we think about how to plan clinical trials and what to expect. And particularly how to take that in the context of newer data with regard to the addition of treatments such as the CDK4/6 inhibitors. So again, a really elegant and important abstract that was shown to us. I'd like to pivot next to the ASTRA 70 trial presented by Dr. Etienne Brain. And this is a trial that was specifically looking at what is the best adjuvant therapy for women over 70 with breast cancer. And so this was a really, I think the term was tour de force effort to enroll patients over this age of 70 years who had hormone receptor positive, HER2 negative breast cancer of any T stage and of any N stage. And the goal here was to use a biomarker called the GGI genomic index to help predict and identify those patients with a high score for whom the idea was to determine whether the addition of chemotherapy in addition to endocrine therapy would be helpful. And so this was a trial that enrolled a very large number of patients. They used a single consent. Patients underwent screening where the tumor was sent for the GGI test that turned around in 2 to 3 weeks, similar to an Oncotype. And then those patients with higher equivocal GGI were randomized to receive endocrine therapy only or chemotherapy followed by endocrine therapy. The chemotherapy that was used was pretty thoughtful. It was 4 cycles, and that was primarily anthracycline AC or doxorubicin or a taxane-based regimen, a TC-like regimen, and then they received radiation and endocrine therapy. Those patients with low GGI scores did not receive chemotherapy based on assessment of low risk. When we look at the selected tumor characteristics, again, these are about 40% of patients had early stage T0 to T1 disease. There were a good proportion of patients with lobular breast cancer, and I would note that those with low GGI scores who were not randomized made up a greater proportion. Grade 1 and 2 and 2 and 3 are shown here, with again a lower proportion of patients in the non-randomized low GGI section who had PR negative disease. So pretty typical of what would be anticipated, and again, no differences between the randomized arms. So when we look at the primary analysis, patients actually, again, did well overall. However, the statistical power was set to see a difference of approximately 10% in overall survival. So it was powered for OS, for a difference with the addition of benefit from chemotherapy. And really, we did not see that in this patient population. And so when we look at overall survival by intention to treat in the endocrine therapy only arm, at 4 years, that was at 89% versus 90%, but that did not meet statistical significance with a confidence interval crossing 1. It's important to realize that about 20% of the patients on this trial actually did not receive their assigned chemotherapy. And so when they looked at overall survival by the intention to treat protocol, or by protocol design, meaning having received their chemotherapy, that benefit again was 89 versus 91% of patients alive and well, and that hazard ratio was at 0.73. And so again, a suggestion here that the GGI score did not seem to predict benefit associated with the addition of adjuvant chemotherapy in this patient population. On the next slide, I added just to show that there was good evidence to suggest that this particular GGI score is prognostic, but doesn't appear to be predictive. And so you can see here that the overall survival probability of patients with low scores versus higher equivocal, that it clearly could discriminate was prognostic, but again, as I've shown, was not predictive of benefit. And so Dr. Davidson's thoughts about this study were that it was obviously a really heroic and large effort to focus on older or elderly patients that had very open inclusion criteria. They used a custom biomarker panel, GGI, which makes it a little bit more difficult to contextualize in the context of Oncotype and MammaPrint, which are much more commonly used in our practices. The overall survival is the primary endpoint, with a long median follow-up is also incredibly important. And the chemotherapy regimens and the adherence were similar to what have been observed for other studies like MIND-ACT and Responder with regard to adherence rate. The GGI score is prognostic, but was not able to predict overall survival benefit with the addition of chemotherapy. And Dr. Davidson felt that it seemed unlikely that this particular biomarker score would be developed further. Again, this trial doesn't help us with regard to thinking about high-risk patients for whom CDK4/6 inhibitors, and didn't evaluate the incorporation of bisphosphonates in this data. The good news here is that this is a wonderful collection of data that included, I believe, some patient-reported outcomes and quality of life scores, which I'm sure will be fruitful for a number of additional studies and publications down the road as well. And so Dr. Davidson used this as an opportunity to talk recently about the recent updates to ASCO guidelines for adjuvant endocrine therapy and chemotherapy and the use of biomarkers. And she pointed to the recent publication from 2022 that talks about the careful review at levels of evidence for the biomarkers that we use to make decisions about benefit or use of adjuvant chemotherapy in different patient populations. You can see here that for patients with who are postmenopausal, we have a number of choices with Oncotype and MammaPrint, and a number of other indices that can be used in the node negative setting. In node positive disease, Oncotype and MammaPrint are highlighted. For premenopausal patients, and then I would point to the fact that for premenopausal patients that are node positive, there's really insufficient evidence to recommend a biomarker for use of excluding chemotherapy. And again, for those with 4 more positive nodes, we are still working on more data there. In terms of deciding on the benefit of extended endocrine therapy for patients with node negative disease, this lists opportunities here to consider for patients who have lower risk disease. There's insufficient evidence to suggest that Oncotype or any of our tests used for early treatment decisions will predict late recurrence. The BCI test may be considered for selected patients with node positive disease. And for patients with greater than 4 positive nodes, there's insufficient evidence for the breast cancer index test at this time. So the next abstract that was discussed was a question from the Korean study group that was evaluating the benefits or the potential use of ovarian function suppression in addition to tamoxifen for patients for premenopausal patients with breast cancer. Unique features of this particular clinical trial was the age of patients included. So these were all patients of age 45 or less who presented with hormone receptor positive stage 1 through 3 breast cancer. All patients enrolled on this trial received surgery and adjuvant chemotherapy with adequate performance status. And the really interesting part of this trial is that they actually followed patients for up to 2 years after completion of their chemotherapy, monitoring and looking for those patients who had a return of ovarian function. So either they had no evidence of ovarian compromise after their chemo, or even if they did have cessation of their periods, if their ovarian function came back, then they were eligible to be randomized 1-to-1 to receive tamoxifen 20 milligrams daily with goserelin monthly. And I would point out that was only for 2 years, not for 5 like soft and text, or to receive standard of care tamoxifen only for 5 years. And so again, they identified and they followed patients to look for those who had resumption of ovarian function after chemotherapy. Patients who experienced disease progression prior to resumption of ovarian function were actually excluded from this trial. Their primary endpoint was disease-free survival with secondary of overall survival. When we look at this patient in the ASTRA study, the patient population compared to soft, again, these were particularly younger women, 45 or less. Their median age was the same as soft at age 40. About half, a little more than half, had lymph node positive disease, and a similar proportion with HER2 positive disease. And again, they evaluated a longer period of time for potential ovarian recovery and a shorter duration of ovarian function suppression. Dr. Kim presented the results of the ASTRA trial with now long-term follow-up at 8 years of median follow-up here. And what you can see is that the addition of ovarian function suppression to tamoxifen offered an advantage with regard to both disease-free survival as well as to overall survival. But all of these patients experienced overall excellent follow-up. And I was sorry to say here, it was in terms of this is disease-free survival, not overall survival. My apologies. And so again, this was for disease-free survival, and you can see a numerical advantage that begins smaller at 5 years, but greater as time goes on, with an absolute benefit noted here, and an excellent overall survival for both groups. And so in summary, regarding the ASTRA trial, this was a distinctive trial in that it was looking at a potentially younger and higher risk group of premenopausal patients. All patients received chemotherapy on this trial, and they again looked for ovarian recovery for a longer duration. The design and the follow-up were excellent, and there was no new information provided about long-term side effects except second cancers, which I'm not showing here. This did show potentially an advantage to a shorter course of monthly ovarian function suppression with goserelin, 2 years as opposed to 5 years, which was evaluated in text. And again, the interpretation here is a little bit compromised There's potential interference with the context of using aromatase inhibitors for our highest risk patients, the potential additional benefit of bisphosphonates, or longer use of ovarian function suppression. And we need to consider these findings in the context of the 12-year follow-up of the SOFT and TEXT trials, which was presented at San Antonio also by Dr. Reagan. And what you can see here are the absolute benefits in terms of tamoxifen with ovarian function suppression showed an absolute reduction in distant recurrence of 2.6% at 12 years, with a reduction in death, an absolute reduction at 4.7% at 12 years, and shown here. And so we still, for our highest risk patients that are premenopausal, 5 years of ovarian function suppression with exemestane results in improvements that are shown here. Additionally, last trial that we discussed was the ABCSG18 trial by Dr. Michael Gannant. And this is a prospective randomized placebo-controlled double-blind multi-center phase 3 trial evaluating the addition of denosumab versus placebo for patients who are postmenopausal receiving adjuvant endocrine therapy with an aromatase inhibitor. The results of this trial have been well presented. The primary endpoint was reduction in clinical fractures associated, and that was published a number of years ago. Again, this was a study for postmenopausal women, all hormone receptor positive, and who'd received aromatase inhibitor therapy. About 25% or 25% had received chemotherapy, and there was no receipt of tamoxifen or IV bisphosphonates. And again, these results have been shown that where the risk of clinical fractures was reduced by 50% with the addition of denosumab. So in ASCO this year, we saw the results of the additional endpoints 4, 5, and 6, which were specifically to look at disease-free survival, bone metastasis-free survival, and overall survival. And you can see the sample size and the analysis plan. What's really important to notice here is that because of the benefit associated with denosumab that was noted at a much earlier time point, a number of patients did actually were unblinded and potentially crossed over, which are accounted for in the statistical analysis of these results. And so let me go back here. Sorry. So, this came out at an important time, this particular abstract, because the ASCO and CCO guidelines for the use of adjuvant bone strengthening agents had just been updated in 2022 prior to ASCO. And so this is the kind of the state of the art prior to ASCO, where their recommendation based upon other studies was to discuss adjuvant bisphosphonate therapy with all postmenopausal patients who've received systemic therapy regardless of their hormone receptor and HER2 status, and initiation of any of the following with clodronate, abandronate, or zoledronic acid were considered to be options for recommendation. And at this point, earlier prior to this abstract presentation, adjuvant denosumab was not included among this on this list. And so here are the results that were presented with regard to the benefit associated with denosumab. And this is again at a median follow-up of 8 years. And what you can see is that numerically for disease-free survival, for bone metastasis-free survival, and for overall survival, there's a numeric advantage associated with the receipt of denosumab in this patient population. Probably one of the most encouraging parts of this is that there were no new toxicities noticed. And with the dosing of denosumab of 60 milligrams sub-Q every 6 months for the 5 years of adjuvant endocrine therapy, there were no cases of osteonecrosis of the jaw and only one adjudicated case of an atypical femoral fracture on denosumab. And so the safety signal there is certainly reassuring as well. And so when Dr. Davidson did a nice comparison of ABCSG18 to the DCARE study, which was a trial that evaluated the role of denosumab as well. And she did this comparison here that shows the size of the patient and the patient characteristics. Again, DCARE included both pre and postmenopausal patients, many of whom were node positive. And again, chemotherapy was given in most. Denosumab dosing, I would point in the ABCSG 18 study was 60 milligrams every 6 months, whereas the dosing was much more intense in the DCARE study. The median follow-up is long for both, and you can see the hazard ratios for bone metastasis disease-free survival. We also saw that in the DCARE study, the incidence of osteonecrosis of the jaw was substantially higher than what was observed for ABCSG 18. And so in summary here, this was again a large placebo-controlled trial of denosumab in a defined patient population of postmenopausal women with hormone receptor positive early breast cancer. The follow-up was long. The statistical design and the statisticians did a thorough job of evaluating potentially confounding factors with regard to crossover, and the data that was shown was the intent to treat analysis. But this did show that there was an advantage associated with the receipt of denosumab for disease-free, for bone metastasis-free survival. And so Dr. Davidson commented that, ideally we could have a comparative trial of bisphosphonate versus denosumab. That would certainly be ideal, but is very unlikely to occur. And the results of this study support consideration of adjuvant denosumab as an option for this particular patient population of postmenopausal women receiving aromatase inhibitor therapy, and at least as a consideration as an alternative to a bisphosphonate with consideration of toxicity, availability, and cost. And I'm really excited because Purni Manohar, who's here with us today, is doing a lot of work in this very space, and I'm hopeful we'll have some very thoughtful comments on this data as well. And so in summary, Dr. Davidson did a much better job than I of discussing these various important abstracts, including looking at, again, how can we do better to improve long-term outcomes for our patients, and really long-term follow-up is super important here. And these studies continue to bear excellent fruit for us in terms of thinking about how we plan the next set of trials. And I will stop share, I think. And Hannah had a comment here that is very important. Yes, we do have a trial looking at a new formulation of leuprolide that's a 12-week that will be important for us as well. So I will hand it off to Dr. Linden.
And take any questions anybody has while I'm getting my slides up. Can you guys hear me? Yeah. Okay, so thanks, Jen, for sharing Nancy's slides and the oligometastatic slides. We got a lot to think about and a lot to discuss. I'm going to try to give a bit of a metastatic update. Will talked about last time the TDXT trial, the Destiny trial, but there were a few others that were important. And the theme there would be effective therapy for breast cancer is effective therapy for breast cancer. I'm pretty underwhelmed by our understanding of exactly what we're targeting with these conjugates, but they're very active and actually have a pretty good therapeutic index. Okay, so I'm going to talk about a few things that are mostly in the ER positive, HER2 negative group, the sacituzumab trial, TROPiCS-02, the MAINTAIN trial, which is second-line CDK4/6 inhibitor, and discuss this emerging controversy over different overall survival data in the palbociclib and ribociclib and abemaciclib studies. So Dr. Rugo presented this trial, TROPiCS-02, which is really a lot like the trial that got eribulin FDA approved in breast cancer, allowing patients to get physician choice of treatment of very good standard agents versus sacituzumab. And as we know, sacituzumab has been shown to be active in triple negative breast cancer, but it targets TROP2, which is something that's present on all breast cancer cells. So not surprisingly, this trial accrued quickly and showed interesting information, specifically that the outcome was a little better for these patients. So we got their primary endpoint, the independently assessed progression-free survival, was significantly improved, but unfortunately, the data is not mature enough for overall survival benefit to be seen. But I think the moral here is this is active therapy. It's an active agent, and I'm really glad we're going to be able to give it to everyone now, not just the triple negative patients. We've been giving irinotecan, to patients for a long time as one of the options for metastatic breast cancer, but this is a little more targeted, hopefully a little more effective and active. It is chemotherapy though, so it's harsh and arduous for patients. So Claudine Isaacs was the speaker who had a chance to sort of pull all this together for us about the ER positive group and targeted therapies. And I've shamelessly stolen many of her slides to have this discussion. I've also had the chance to really chat with her about this, including through the TBCRC working group, and I'll share some of those discussions. We saw a discussion of the MAINTAIN trial, which was presented by Kevin Kalinsky, which is about adding a CDK4/6 inhibitor after you've already been on one. And we also had a discussion about first-line palbo presented. So if we look at sort of what's our current algorithm, these are Claudine's slides. First line, we're giving an AI or fulvestrant with a CDK4/6 inhibitor, and that's just become what we all do. That's probably not correct, in that there are probably a subset of patients who would do fine without adding the CDK4/6 inhibitor up front. However, we don't exactly know who those are. And because of, an overall survival data, we're really tempted to get out the CDK4/6 inhibitor up front. Are we giving the right one? Because we're mostly giving palbociclib. I think that's unclear. So then what do you do second line? Well, we've seen a lot of resistance, and the EMERALD data was really depressing, showing that when you try to give just single agent endocrine therapy in the second line setting, you don't get a lot of activity. So we are all looking for BRCA mutations, looking for PI3 kinase mutations, and trying to find what we should do second line. And there are many ongoing studies in this space, and one of them was presented, which I'll go over in a second. But I think the standard algorithm would be giving alpelisib or everolimus in the second line setting. Alpelisib would be if you have a PI3 kinase mutation. Unfortunately, both those agents are often very toxic. So we really would all love to see other opportunities for something less toxic in that second line space. And then third line, you could give chemotherapy, or you could continue with endocrine salvage therapy. And certainly this has been something, an area where we're all very interested in investigation, and also an area where potentially FES could really help us. So what's the optimal strategy once you have had disease progression, usually following a long period of disease control and perhaps a more dramatic response than we used to see with the CDK4/6 inhibitors? So not just stable disease, but response followed by ongoing stable disease. But I think we're all scratching our heads here, and we're worried that we've used up endocrine sensitivity once you've progressed following the CDK4/6 inhibitor. There is a question of whether you could continue the very same CDK4/6 inhibitor and just change the dance partner and go to a different endocrine treatment, or similarly keep the endocrine treatment stable and change the CDK4/6 inhibitor, or perhaps you have to do both. The EMERALD trial is now published, and it shows a frighteningly steep drop-off when you just give single agent endocrine therapy, but it does show really that the oral SERD is active, perhaps a little more active than our standard approach, which is fulvestrant. Okay, so in that context, the MAINTAIN data was presented by Kevin Kalinsky, one of our friends through SWOG. And this study was basically trying to be in that second line space, but it could be later than second line. And the intervention was ribociclib, and also switching endocrine treatment versus just switching that endocrine treatment. So the majority of the patients simply had AI palbo and then went on to fulvestrant plus or minus ribociclib. The median duration of response was 16% for the first line therapy, which is probably average, but maybe a little low. And some patients were put on exemestane, but again, the majority got fulvestrant. And the primary endpoint was locally assessed, but also more objective in the secondary endpoints and looking at the clinical benefit rate, safety, and ctDNA. So what did they find? Well, that red curve here looks a lot like the Emerald data. But if you got the CDK4/6 inhibitor, things got a little bit more respectable. And so in this this study, actually, when you look out at 12 months, you've got 24% of patients remaining on therapy, and you've got a much more robust number, really of almost half the patients remaining on therapy with the ribociclib at 6 months. So it's certainly not the degree of response we saw with the first-line therapy, but at least it's somewhat respectable. So this is clearly an option. So this is a well-designed, but really phase 2 trial, and we just don't still know what to do in the second line. It's a small study. It's encouraging that we're seeing activity of second-line CDK4/6 inhibitor, but we don't know really what to do. And multiple studies, some of which are listed here, are very, very reasonable options. But we're still discouraged because we really like to see, much greater amount of activity in this space. We have studies in the second line and beyond here. Our first line FES trial has completed accrual nationally, but we're opening a phase 4 study looking at the impact of FES on clinical decision making. Certainly, it's reasonable if you're on a aromatase inhibitor to look at ER function to help you with this decision. But we will have an oral SARM, ostarine really, enobosarm, plus abemaciclib in this space. And that'll be first with a safety run-in, but then a randomized trial comparing it to exemestane and everolimus, presumably for PI3 kinase negative, but these drugs are active in the PI3 kinase positive patients, so you could consider that as well. We also will hopefully soon have approval to get going with sort of the next gen targeted trial of a tracer, which is a progesterone imaging tracer, FFNP, that you can use to look at ER function downstream. And that trial will is really an imaging trial with serial FFNP, but you can give endocrine therapy of choice, and this study will provide abemaciclib, so that will be another salvage option. I think that what we all think is forthcoming, based on the Destiny trial that Will presented and the Tropics trial, that there will be more immune conjugates versus, broad targets such as TROP2, HER2 low, and HER3. So I think this is an exciting area, but I also want to humbly acknowledge that these are chemotherapy drugs. They're not some stealth targeted therapy without any side effects. You lose your hair and you feel nauseated, so you feel like you're getting chemotherapy. Okay, so shifting gears and hopefully staying on time, wanted to talk about the survival issues with the CDK4/6 inhibitor. So we saw an update in the pallet trial, not my favorite name for a trial. I keep thinking about the pallets that we transport goods on, but this is with this was a analysis of the Paloma 2 data, which is with palbo and letrozole. So just what's amazing here is, thousands of patients participated in these randomized studies looking at the addition of CDK4/6 inhibitors, and we saw remarkably consistent results that adding CDK4/6 inhibitor really dramatically improved the progression-free survival. And we know that in the Mona Lisa trial, which I think has 3 New England Journal publications, and this is the latest, is that we've really moved the bar in terms of overall survival for patients with metastatic breast cancer from 5 years to 6 years. And that's very exciting news. So we know that ribociclib and really all the CDK4/6 inhibitors are a great advance in breast cancer. So remember those numbers: for really almost versus 54 months. Ribociclib has also been shown to improve survival in perhaps our most high-risk group, the premenopausal women with ovarian suppression, and also when you give it with fulvestrant. And some of the patients on this trial actually had AI alone before they got the fulvestrant, so it really wasn't first line, it was second line. But this is impressive that ribociclib has 3 trials that improve overall survival. Okay, so we were all kind of wondering what this data would show. Would palbociclib also show improved survival? Same setting, first line, postmenopausal women. And we participated in this trial. And like many other oncologists, we learned to give palbociclib. And we helped people, but you can see that the overall survival is not different between these 2 groups. So disappointing news here. What's the difference between these studies? Well, there's a huge difference. It has to do with which patients go on the study. So all studies have eligibility criteria, and we all know that certain categories of patients tend to do better than others, and people who recur within a year of their primary treatment are in a very high risk group. And only PALOMA-2 allowed enrollment of these patients. So you can see for the people who are actually enrolled, there was a significant chunk of patients who were really high risk to begin with. So what happens if you remove those people? You cherry pick after the fact. You find out that you have a very similar improvement in overall survival. Now, it's post hoc analysis, it's not fair, and there's some missing data, but I think this is just complicated and we're still sort of learning. So there may be differences between the 3 FDA-approved CDK4/6 inhibitor, but we have a problem in that the trial's underpowered, and actually both arms outperformed expectations, which throws your statistician a curve. And we all know that patients who recur early are high risk. So we need some prospective data to compare the CDK4/6 inhibitors in order to really know which to recommend. We need more long-term data from Monarch 3, and we're also awaiting data from the NATALEE trial. So one of my questions is, would overall survival be the same if you crossed over? And this is an FDA issue. They didn't allow enough crossover. So just a reminder that in all these trials that are showing improved survival, many of the patients in the control arm were not allowed to get the effective agent later, which to me is an ethical miss. So what should we do? Well, only abemaciclib is FDA approved in the adjuvant setting, so that's all we can give, and we're giving it to the high-risk patients because that's who it's approved for. I think we have to acknowledge that ribociclib has had 3 large, well-done trials which show overall survival benefit, but the progression-free survival is identical for all the agents. So I think you should consider ribociclib as the current best out-of-the-box CDK4/6 inhibitor. But given the reality of looking back and analyzing patients who are in the exact same category, I would not discontinue palbo and switch to ribo in patients who are undergoing therapy, as it's very effective therapy. And you also have the option to give the ribociclib in the future. And this whole topic that I just presented, the second half here, this was discussed extensively at our last TBCRC meeting. And what I'm telling you is not just what I'm thinking, but what actually the national group was thinking as well. We're still not fully convinced that ribociclib is that kind of a game changer. So thanks for your attention. I think that's the end of my series of slides, and we are happy to take any questions, and I can now look at the chat. Yeah, Porny, thanks for mentioning the rebound bone loss, which is one of the key problems for denosumab. And of course, people can get osteonecrosis of the jaw later as well. Other thoughts from the group? I think it took us 2 hours, but we got through most of what was presented that was headline at ASCO. Thanks, Jen, for taking your lunch in clinic with us, and for everybody for spending time on a sunny day online.
Great. Well, thanks everyone. Take care and enjoy the rest of your day.